Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article.
Welcome to SummaryCast.
Today, we're looking at a new way to sharpen preoperative risk stratification in endometrial cancer.
This comes from a paper in the August 2026 issue of the Korean Journal of Radiology. It's titled Preoperative Prediction of Lymphovascular Space Invasion in Endometrial Cancer, using diffusion MRI-derived vessel density.
A long title. Let's break it down. Endometrial cancer is a significant concern, and its incidence has been on the rise.
It is. The paper notes it's the second most common gynecological malignancy in China, and accurate risk stratification before surgery is essential for guiding management.
What does that mean in practice? Risk stratification.
It's about categorizing patients into groups, like low risk or high risk, based on features of their tumor. This helps determine how aggressive the treatment needs to be. For instance, European guidelines identify lymphovascular space invasion, or LVSI, as a crucial component of this process.
Right. And knowing the LVSI status beforehand directly impacts the surgical plan.
It does. It's a major decision point. The presence of LVSI is strongly associated with lymph node metastasis, pelvic recurrence, and just generally poorer outcomes.
So it changes the surgical approach, specifically around the lymph nodes.
Exactly. It's a key factor in deciding whether to perform a lymphadenectomy, which is the surgical removal of lymph nodes. That procedure has its own risks, like lymphedema, so you don't want to do it unnecessarily, especially for low-risk patients.
And currently, assessing LVSI is a post-operative exercise. You get the definitive answer from the pathologist after the surgery is already done.
Precisely. Methods like preoperative biopsy or intraoperative frozen sections can provide some information, but they are both subject to sampling error. You can easily miss microscopic vascular invasion.
So there's a real need for a reliable, non-invasive method to predict LVSI before the first incision is ever made. Conventional MRI gives us great anatomical detail, but it can't really see this biological activity.
That's the problem this paper is trying to solve. They're evaluating a simplified metric from diffusion MRI to do just that. It's a functional MRI technique that goes beyond just anatomy.
And this metric is called?
Diffusion-derived vessel density, or DDVD. The idea is to get a quantitative look at the tumor's microvascular environment without needing contrast agents and with much simpler post-processing than other advanced techniques.
Simpler than what, specifically? What's the more complex alternative?
The main comparison here is a technique called intravoxel incoherent motion, or IVIM. IVIM is a sophisticated model that tries to separate two different things happening within a single imaging voxel.
Okay, what two things?
First, there's the true diffusion of water molecules within the tissue, which is represented by a parameter called D. Second, there's the pseudo-diffusion effect caused by blood flowing through the tiny capillary network. This is quantified by a parameter called D star.
And IVIM separates these two signals.
It does, using a bi-exponential fit across multiple B values. It also calculates a third parameter, F, which represents the perfusion fraction, basically what fraction of the signal comes from that microcapillary blood flow.
But that process can be finicky. It's sensitive to how you select your B values, it can have long acquisition times, and the post-processing is complex.
You nailed it. It can have substantial inter-study variability. DDVD is, by comparison, deceptively simple.
How does it work mechanically?
It's derived from the signal difference between just two images, one acquired at a b-value of 0 seconds per square millimeter, where everything is bright, and another at a very low b-value. In this study, they used 10 seconds per square millimeter.
Okay, why that specific comparison?
Because the signal from blood flowing in microvessels is extremely sensitive to diffusion weighting. It attenuates very rapidly. So that drop in signal between b equals 0 and b equals 10 acts as a direct surrogate for the microvascular signal contribution per unit of tissue.
So it's a clever shortcut to quantify perfusion effects without the full complex IVIM model.
That's the beauty of it. It's a more pragmatic approach.
So they have this new metric. How did they go about testing it?
This was an exploratory retrospective study. They started with 273 patients, and after applying exclusion criteria like prior treatment or poor image quality, they ended up with a final cohort of 194 patients.
All with histopathologically confirmed endometrial cancer who had undergone a preoperative multi-B-value DWI exam.
That's right. They were all scanned on a 3T GE scanner, and the DWI protocol was quite comprehensive, using 12 different B values ranging from 0 to 1,000 seconds per square millimeter.
And what was the breakdown of LVSI status in that final group?
The cohort included 126 patients who were LVSI negative and 68 who were LVSI positive.
About a 2-to-1 ratio. It's a decent number of positive cases to analyze. And for each patient, 2 radiologists independently delineated the tumors to extract the quantitative data.
They did, and it's worth noting that the inter-observer agreement was excellent. The intra-class correlation coefficients for all the quantitative parameters were above 0.92.
That's a crucial point. It means the measurements themselves are reliable and reproducible, at least between those 2 readers. That's a necessary first step for any quantitative biomarker.
Absolutely. So with this reliable data, they set out to build and compare predictive models. First, they looked at the individual imaging parameters. Then they built a model using only standard clinicopathologic variables.
Things like histologic grade, tumor stage, depth of myometrial invasion, and serum CA-125 levels.
Yes, the established prognostic factors. And finally, they created combined models to see if integrating the imaging markers with the clinical data could improve predictive power.
Let's start with those baseline clinical factors. Did the LVSI positive and LVSI negative groups look different even before looking at the advanced MRI data?
They certainly did. Compared to the LVSI negative group, the LVSI positive patients had higher serum CA-125 levels and larger tumors. They were also far more likely to have deep myometrial invasion, 50% of the positive group versus just 10% of the negative group.
And pathologically?
The LVSI positive group had a less favorable profile. Non-endometrioid histology was more common, as were higher histologic grades and more advanced tumor stages.
So LVSI is clearly part of a more aggressive tumor phenotype. It doesn't exist in a vacuum. Now, let's bring in the imaging. Did the diffusion maps add to this picture?
They did. The analysis showed that LVSI-positive tumors had significantly lower values for the standard ADC, the IVIM perfusion fraction F, and the new DDV metric.
Lower. That feels a bit counterintuitive. You'd think a more aggressive tumor would have more blood vessels, so a higher perfusion signal?
That's a great catch, and it's a key point of discussion. The thinking here is that while aggressive tumors do undergo angiogenesis, the new microvasculature they create is often immature, disorganized, and functionally inefficient.
So you get these leaky, chaotic vessels that don't actually contribute to effective tissue perfusion. And you might see more intratumoral micronecrosis as well, which wouldn't have a perfusion signal.
Precisely. So the effective intravascular signal that these perfusion-sensitive DWI techniques capture is actually reduced. It's a case where more vessels doesn't necessarily mean more function.
It's interesting because in other cancers, like gliomas, some studies have found higher DDVD values associated with more aggressive features. So this relationship isn't universal.
That's right. The underlying biology is complex, and this mechanistic interpretation is still speculative. But in this specific context of endometrial cancer, lower perfusion metrics were consistently associated with LVSI.
Okay, that makes sense. Let's quantify the performance. How did the different predictive models stack up? Let's talk area under the curve, or AUC.
Starting with the individual imaging markers, the perfusion fraction, F, on its own achieved an AUC of 0.692.
That's only moderately predictive. Better than a coin toss, but not by much.
Right. The new metric DDVD performed better, yielding an AUC of 0.772.
Okay, a noticeable improvement. Was that difference statistically significant?
It was numerically higher, but after applying the Bonferroni correction for multiple comparisons, the difference between the two was not statistically significant. So DDVD is trending better, but maybe not definitively superior on its own.
Fair enough. Now, what about the baseline model, using only the standard clinicopathologic factors?
That CP model was actually quite strong by itself. It reached an AUC of 0.848.
That's a very solid baseline. It tells us that things like tumor grade and stage are already powerful predictors. So the real test is whether adding an imaging marker like DDVD provides any additional value on top of that.
It does, and this is one of the important findings of the study. When they combined DDVD with the retained CP factors, the model's AUC jumped significantly to 0.895.
So from 0.848 to 0.895. That's a meaningful improvement in discrimination. The imaging is clearly adding information that the clinical factors are missing.
Exactly. The difference between the combined model and the imaging-only model was statistically significant, with a p-value of less than 0.001. They also performed bootstrap resampling with 1,000 iterations to check the stability of these models.
What does that tell you in plain terms?
It's a statistical method to check if your result is a fluke. You repeatedly resample your own data to see how much the model's performance varies. In this case, the AUC distributions were relatively concentrated, which suggests the models are internally stable and the performance they observed is likely robust.
Good. So the 0.895 AUC is probably a reliable estimate for this data set. What about the F plus CP model?
That model reached an AUC of 0.868, significantly higher than 0.692 for F alone, with a p-value of less than 0.001. And the most complex model, which included F, DDVD, and the clinical predictors, achieved the highest AUC of all at 0.904.
0.904. It's the highest number, compared with 0.868 for F plus CP and 0.895 for DDVD plus CP. But was it meaningfully better?
That's the interesting part. The paper reports that the fully combined model was not significantly different from the DDVD plus CP model after Bonferroni correction. Adding the IVIM-derived F on top of DDVD and the clinical factors offered only a marginal, statistically insignificant improvement.
So the bottom line from the data seems to be that DDVD is a feasible biomarker, and its real power is unlocked when you combine it with standard clinical risk factors.
That's the core takeaway. It provides independent predictive information. It's capturing a biological signal related to tumor perfusion that complements the anatomical and histologic information from the other variables.
And the results also suggest that a more parsimonious model is likely the best approach in practice.
You're right. Why go through the extra steps and computational complexity of a full IVIM analysis to calculate F if the simpler DDV plus CP model performs just as well as the all-inclusive one?
Right. Simplicity and robustness are key for clinical translation. Which brings us to the limitations. This is an exploratory study. What's the catch?
The primary one is the study design itself. It is a retrospective, single-center study.
And there was no independent validation cohort, so we have no idea if these specific models and their performance metrics would hold up at a different institution using a different MRI scanner or a slightly different protocol.
Correct. Generalizability is the major unanswered question. Prospective multi-center validation is warranted.
What else?
The second point is that the diffusion acquisition protocol used in the study was originally designed for IVIM analysis, not specifically optimized for DDVD.
So it might not be the best possible way to measure DDVD. Then there's the workflow issue. The authors note that they used manual slice-by-slice segmentation of the entire tumor.
Yes, and that is a significant practical barrier. It's time-consuming and introduces reader variability. For this to be a tool used in routine clinical practice, you would absolutely need efficient and reliable automated or semi-automated segmentation methods.
That's a non-trivial engineering challenge. A great biomarker that no one can measure consistently is useless. I also noticed a gap in the validation.
What's that?
The lack of direct histopathological correlation. They measured vessel density with an MRI signal surrogate. But did anyone go back to the pathology slides and actually count the microvessels to see if the DDVD value truly correlated with the underlying microvascular anatomy? The paper identifies this as a limitation.
An excellent point. That direct correlation is missing, so the biological interpretation remains an inference. Another forward-looking limitation they mention is the absence of molecular classification data.
Right. Modern endometrial cancer care is increasingly driven by molecular subtypes, pole-mutated, mismatch repair deficients, and so on. Where does DDVD fit into that framework?
We don't know yet. A critical next step for future research would be to integrate this type of imaging data with molecular profiles to see if DDVD can serve as a non-invasive surrogate for certain molecular states or provide prognostic information that's independent of them.
Okay, let's lay this. If I had to summarize the study, I'd say DDVD appears to be a feasible and promising imaging biomarker for preoperatively predicting LVSI in endometrial cancer.
I agree. It's simpler to derive than parameters from a full IVIM analysis, and it shows real power when integrated with established clinicopathologic risk factors.
It enhances preoperative risk stratification, which is the whole point. It could help guide conversations about surgical planning and patient counseling.
But it's early days. The findings need to be validated in a prospective multi-center setting. The acquisition and analysis workflow needs to be optimized and automated to make it practical.
And its link to the underlying histology and molecular biology needs to be more firmly established. Still, it's a very neat demonstration of how a relatively simple, quantitative imaging metric can add significant value, moving toward more personalized, data-driven surgical planning.
A really nicely engineered study that paves the way for a more streamlined, non-invasive biomarker.
That is all the time we have for this episode of SummaryCast.
Join us next time.